I just love seeing all of my old friends and current friends and new friends come online like this. It's such a satisfying thing to me personally. It really is. Dr. Fisher, I have to think back in time and 5 years ago, and I know you know Dr. Craig Fisher at UT Southwestern. And I met with Dr. Fisher, not Fisher, I'm sorry, Glazer.
Yeah.
You're Dr. Fisher. Dr. Craig Glazer here at UT Southwestern, who trained with Dr. Cosgrove, who you know well at National Jewish Health.
Yeah.
And Dr. Cosgrove contacted me to help Dr. Glazer establish the PF Warriors, and that was like 5 years ago. And every time I see this wonderful turnout we have, and all of our warrior members that join us, I can't describe to you the sense of satisfaction and joy I personally get, because we've now grown to an organization exceeding 2,000 people, and we reach many, many more. And I think the education we brought and the inspiration we brought it's perhaps hard to measure, but it is so meaningful to see. So I would remind those that are attending this meeting that aren't currently PF Warriors before we start, please join us. You'll get alerts on meetings like this. We do 2 formal meetings a month. This is one of our formal meetings. We're doing a whole series of other private meetings between patients and each other and others. And you get registered on our site, which is at pfwarriors.com. You'll have access to all of our existing videos. We have videos going back 5 years, different speakers and presentations. You'll have our free guide, our patient guide, which is a 40-page guide on living with this terrible, terrible disease, plus other things such as participation in Dr. Noah Greenspan's boot camp. We have a complimentary membership for you. So it all starts with taking a second, registering, and we welcome patients, we welcome medical professionals, caregivers, and families. With that, I'm going to introduce Shelley Mathis, and Shelley Mathis is our Vice President of Events and much, much, much more. She keeps us aligned. She's my personal nag to do things right, and she does it real well. And she's also very responsive as far as running the back end of our organization. You have to keep in mind we're a large organization, and she's responsible for all of our accounting and bookkeeping and the business side of what we do. So with that, I'm going to introduce my friend as well as a caregiver, and her husband, Scott's a fellow patient. So Shelley, you are on.
Thank you, Bill. It's a real pleasure to get to introduce Dr. Fisher. My husband has rheumatoid arthritis, interstitial lung disease. After showing pulmonary problems for years, like constant coughing and being short of breath, he began to show the signs of rheumatoid arthritis in 2014 and finally got the correct diagnosis. Since he had shown lung disease years before his diagnosis, he qualified for a study at the University of Colorado, where they were studying patients like him. And that's where we were told about Dr. Aryeh Fischer and the work he was doing in the area of autoimmunity and fibrotic lung disease. He was considered the best in the nation for his work. We also got to meet him in November at the PFF Summit in San Antonio, and his kindness, concern, sincerity, and generosity came through, so we asked him if he'd speak to our group, and he agreed. Now, Dr. Aryeh Fischer is Senior Clinical Trial Physician, Lung Fibrosis and Immunoscience and Fibrosis Drug Discovery at Bristol Myers Squibb. Dr. Fischer transitioned from academic medical career in 2019, August of 2019. He had most recently served as Associate Professor of Medicine within the Division of Rheumatology and the Division of Pulmonary Sciences and Critical Care Medicine at the University of Colorado in Denver, where he served as Director of the Autoimmune and Fibrotic Lung Disease Treatment Program. Thank you, Dr. Fischer, for joining us today, and the show is now yours.
Thank you so much, Shelley. Thank you for your kind introduction. And great to see you again, Shelley, see you, Scott, and thank you to Bill, and really Bill and Shelley, who've spent countless times now emailing back and forth and setting this up. It's a real pleasure and a real honor. It's always humbling for me to speak to patients and their caregivers on the topic of lung fibrosis. So I approach this with a fair degree of trepidation and I think humility, because while I have taken care of patients with this illness, have studied it, have been involved in research, speak a lot about it, and read a lot about it, I don't have it. And it's not, in my family, and it's not affecting one of my loved ones. And so I want to just be, cautious, careful, and mostly I want to make sure that I remain humble about the disease and all that it can do. I learn so much when I speak and interact with patients. You all teach me a ton about living and about challenges and how to face them in life. And that applies to patients' caregivers also. So again, I'm honored and truly humbled, with regards to the task at hand. I'm going to ask Bill or Shelley just to make sure that my screen is projecting okay and that you all are hearing me okay.
Yes, we can see.
Great, perfect. And I threw in the y'all for Bill and Shelley with the whole Texas thing. I would also be remiss to not wish everybody well during the times of COVID and the pandemic we're all facing. And when you think about how the world has changed, here I am in my home office in Denver, Colorado, speaking on a webinar to folks around the world. And so obviously there are some opportunities that we have, and we've become more faceted in our communication as a result. We're all Zoom experts. Certainly Bill is. But I also want to wish everybody well. The lung fibrosis population is particularly at risk for COVID, as you all are aware. And so I just hope that people are getting through and adjusting, doing the best we can. I'm here to talk about the immune system and lung fibrosis. And I want to just be clear that the messages that I'm sharing are mine. I work for a global pharmaceutical company, Bristol Myers Squibb. This is these are my thoughts, my opinions, my content, my slides, and do not reflect anything related to Bristol Myers Squibb. I think it's really important that we ground the conversation, so to speak, and or start at a basic level just to ensure we're all using the same terms. We use the term interstitial lung disease interchangeably with pulmonary fibrosis or lung fibrosis. And what we mean by that categorization is that the tissue of the lungs, what we call the interstitium, is either inflamed or scarred. And scar, we use the term fibrosis. So we really are talking about a diverse group of diseases. It's not just one disease that can show up, that can manifest with inflammation or scarring in the lung. And we'll refer to that scenario either as interstitial lung disease or ILD. We'll refer to it as lung fibrosis or pulmonary fibrosis. And we recognize that many things can cause lung fibrosis. And I'll use those terms interchangeably, lung fibrosis and interstitial lung disease. So for example, rheumatoid arthritis is a well-known cause of lung fibrosis. Certain exposures, such as silicosis, silica from rock construction, or coal can cause coal mining, even smoking. Certain feathers and bird-related droppings can cause lung fibrosis. And sometimes we can't find a cause, and that's when we call it idiopathic. A patient does not have an identifiable cause. We call it an idiopathic interstitial lung disease or idiopathic interstitial pneumonia. I think the best one I've heard from patients is that idiopathic is a reminder that the doctors are quote unquote idiots. They can't figure out what's wrong. So if that helps you remember it, by all means, we don't take it personally. Now, in terms of what this looks like, I tend to try to make this visual for my patients. This is an image of a patient that has interstitial lung disease. We call this a coronal image. The patient's upright. And you could see the arrows that demonstrate where the lung is pretty normal. And those little white specks in the lungs are airways and blood vessels. And then you could see in the lower lung where it's pretty cloudy, distorted, and certainly looks different than it does in the upper lungs. That's the lung fibrosis. That's the ILD, the interstitial lung disease. So this patient has probably about the lower thirds of their lungs inflamed or scarred. And you really would need a lung biopsy to know how much is inflamed versus how much is fibrosis, is how much is scarred. We look at CT scans this way also. This is a much harder image to comprehend than the one before it. In this picture, the patient is now not upright, the patient is now on their back. They're in a CT scanner, they're lying on their back. And if you're looking at this picture straight on, it's almost like the patient's feet are kicking us kind of in our face right now, because they're laying flat on their back. Their feet are coming right toward us, and their head is through the machine, and now we're taking a slice. So this is a much more difficult picture to, I think, comprehend. And so the arrows are to try to orient the audience what we're looking at. We're looking at the lung tissue that I showed you on the slide before. The lower thirds is either inflamed or scarred. One of the things that's, I think, helpful to do, and I would encourage patients and their caregivers to ask their doctors to show them their images, because I think it allows this to be less abstract and perhaps more easily understood when it's seen this way. I like to try to get a sense as to how much a patient's lungs are involved. So I'll look at 3 different slices as an example. So my left big image is the coronal upright, and you can see the lower lung zones are really inflamed or scarred. And then if you look to the right, those 3 different slices will show you that the upper lungs in slice 1 are pretty free, pretty clear with regards to not having lung fibrosis. The middle slice has a little bit of haze that one can see, but not much there either, but the lower lung zones are inflamed or scarred. So this is what lung fibrosis looks like. And when we talk about lung fibrosis, how is it possible that a rheumatologist could focus on this and on this space? So I trained as a rheumatologist, and we didn't focus much at all in our rheumatology training about lung fibrosis, which I think is a problem, truthfully, because if you look at the lung fibrosis classification schemes, as I highlight in the box there, connective tissue disease, which is a weird term, but what it really means is essentially the autoimmune diseases that rheumatologists see. These are the systemic autoimmune diseases that, again, a rheumatologist is focused on. That's a huge category. About 1/3 of all of the interstitial lung diseases tend to be related to the immune system. So when I say that in my rheumatology training we didn't focus on lung fibrosis, I would say, well, why the heck not? We sure should be, because there's a lot of lung fibrosis that rheumatologists will encounter. Now, the other part of this is that the lung fibrosis doctors essentially need to be immune specialists as well, because if they're seeing a lot of lung fibrosis, they better know a lot about the immune system diseases that manifest, that show up with lung fibrosis. So that's obviously the focus of the talk today. When we talk about the classification, it's important to remember that there are other things that cause lung fibrosis, like exposures, which I mentioned, sort of a kind of, I think, difficult to diagnose and complex disease called sarcoidosis or sarcoid. But we give a lot of attention to IPF, idiopathic pulmonary fibrosis. And we do so because that has had its own paradigm of treatment, different from the other diseases. So we talk a lot about IPF, but I applaud the global landscape and PF warriors for really extending beyond IPF, because IPF is the paradigm and we anchor around IPF, but there are lots of other lung fibrosis conditions. So rheumatology. Rheumatology is an unusual field in that we touch multiple specialties. We could have a discussion about the immune system and the skin, and different autoimmune rashes. We could talk about the immune system and the joints and all kinds of inflammation in the joints that we see, or kidneys, or the eyes. Certainly, the lung stands out. And the lung stands out because the autoimmune diseases really love to cause trouble in the lungs. Terminology is challenging. We use the term connective tissue disease. We also will read the term collagen vascular disease. These are terms I'm convinced that are there to confuse our patients. They're historical terms. They don't mean a lot in practice. They are confusing terms. What we really are talking about are the autoimmune diseases that are systemic in nature. Meaning, in contrast to type 1 diabetes, which is an organ-specific autoimmune disease, or MS, multiple sclerosis, one organ, or the thyroid autoimmune diseases, one organ. That's outside of rheumatology. Rheumatology is about the autoimmune diseases that are systemic, multiple organ involvement, the lungs, the eyes, the skin, the joints, the muscles, etc. And they're very different. And being able to learn from one and apply to the other is not as straightforward. So saying that because rheumatoid attacks the lungs this way, so should lupus or scleroderma, that's not necessarily fair or accurate. And so there's a lot of complexity, and there are a lot of different ways that these diseases will show up. What we don't really understand is why some of our patients with these autoimmune disease presentations, why some get lung fibrosis and why others don't. Why is it that one type of scleroderma does, one type of scleroderma doesn't? Rheumatoid can, rheumatoid doesn't have to. Lupus, the same. So we really are still trying to understand why some with these autoimmune diseases have lung fibrosis and why others don't. Now, I should have said this at the outset. I aimed high with this slide deck and presentation. This is the kind of information I share with doctors, lung doctors, rheumatologists, other practitioners. And so I'm asking the audience, I know many of you are experts in the disease already, but again, this is to some review, but to some new material. And some of this is, I think, complex material. A primary message here, though, is that when we encounter this type of scenario, the CAT scan here shows that there is lung fibrosis, there's a real effort, and an extensive one, that tries to find out where this patient sits with regards to all of these question marks. Is it a genetic issue? Is it an occupational? Is it smoking related? Is there something in the environment? Could it be that this is some infection, and COVID, for example, really causes a lot of lung inflammation? So just as an example, when we see interstitial lung disease, all of these things need to be considered. The idiopathic group is the group that has none of these identified. So we've excluded all of the above. We're here to focus, though, on that bottom left, that what we call connective tissue disease, interstitial lung disease. So that just means that it's an interstitial lung disease that's autoimmune in nature, related to a rheumatic disorder. Why? Why do we bother? Well, there are a lot of reasons to bother. I mean, first of all, patients want to know what they have, right? So what is the diagnosis? Is it rheumatoid-related lung fibrosis? Is it an exposure-related lung fibrosis? Is it idiopathic? So there's obvious reasons why. I'll tell you, though, there are other reasons that are really important as well. We may treat conditions differently based on the underlying condition. If it's a rheumatoid lung fibrosis patient, maybe we should treat the rheumatoid arthritis. If it's lupus, let's treat the lupus. If it's environmental, let's remove the environmental problem that may be propagating, worsening the lung fibrosis. If it's IPF, idiopathic pulmonary fibrosis, we now have pirfenidone, we now have nintedanib. So treatment may really be different. I can't stand showing survival curves in general, and I have extreme trepidation when I show them to patients, because survival curves from papers that are published don't always reflect real world evidence, and certainly never can apply to a given patient. So I don't want anybody looking at this thinking that we as doctors can really tell patients how they're going to do, how long they have. We're horrible at that. And don't look at this slide and do the math, because you'll be wrong every time. What this curve tells us, this is from a study out of South Korea, a referral center that really can't be applied to given patients, but we can try to get a better understanding globally. If we look at populations, who does better as a group, who may do worse as a group. And I think it's a fair thing to say that as a group, immune-related lung fibrosis, the autoimmune conditions with lung fibrosis, tend to do better. They tend to live longer. Can't bring it down to the individual patient, but broad strokes, we would say it can be helpful to know if it's autoimmune, because it can be associated with a better longer-term survival compared to, let's say, IPF. Not always the case, but that's another reason we may think this is important. Now, I mentioned treatment. This is an evolving story, but before October of 2014, before the FDA approved pirfenidone and nintedanib for IPF, before then, the treatment for IPF really was a clinical trial or a lung transplantation. And we learned that IPF, when treated with immunosuppression, things like prednisone, things like azathioprine, they sometimes could be harmful. So we learned before the advent of the antifibrotics that we didn't have much for IPF, and everything to the right of this vertical line, really everything, would be treated with immune suppressing therapy. So it may be important before pirfenidone and nintedanib to make that IPF diagnosis, because essentially I wouldn't give immunosuppression to IPF, whereby everybody else is getting immunosuppression. So again, another reason for diagnostic certainty. Now, after October of 14, with pirfenidone and nintedanib available, the paradigm shifted, whereby now everybody to the right is still getting immunosuppression. All those lung fibrosis patients on the right side of that vertical line which is essentially everybody except for IPF. Everybody except for IPF is getting immunosuppression if their lung fibrosis is getting worse, is a problem. And everybody to the left, meaning IPF alone, now has access to pirfenidone or nintedanib, and of course, clinical trials and lung transplant remain an option. So these last two slides are there to try to highlight why we take effort to try to make an accurate diagnosis. Now I'm talking about the immune system, and if one were to ask, well, you just listed all those diseases. You said lupus, you said rheumatoid, you threw in some scleroderma. Which of the diseases are we really discussing? This was from my old clinic in Denver, and we looked at the autoimmune patients that had lung fibrosis in our center. I can't say that this is applicable to other centers around the world. This was our center. And we all know that these centers can be sometimes unusual in that they have not the best representation of real world. You know, we work in an academic center. It's not private practice. It's Colorado. It's not New York. It's not Brazil. It's not Japan. It's our clinic. We saw a lot of SSC, which is for scleroderma. We saw a lot of rheumatoid. We saw a lot of myositis, muscle inflammation. This orange slice is the lupus slice. We didn't see much lupus and lung fibrosis. We saw a lot of, or a fair bit, I should say, of Sjogren's and lung fibrosis. And we saw a lot of a group of patients that weren't able to be reliably called, let's say, rheumatoid or scleroderma, but had an autoimmune flavor to them. This entity that we call IPAF, which we'll talk about a little bit later, which stands for interstitial pneumonia or interstitial lung disease with autoimmune features. So we saw a lot of patients that looked autoimmune even if they didn't have a full-blown autoimmune disease that rheumatology could reliably label as, let's say, rheumatoid or lupus per se. I want to take a step back and open up the world of what goes on in lung fibrosis programs. What we do is we work as a team, ideally, and we try to integrate what the patient brings, meaning their clinical story, what our testing shows by blood work sometimes, what our CAT scan looks like, and if a biopsy is done, what the biopsy shows. We want to integrate all of that information to work hard to get the diagnosis right. And so a standard approach is to do just that, to work as a multidisciplinary unit to do the best we can to make a reliable diagnosis which should then potentially impact treatment. I would argue that considering how much immune system disease is involved in the lungs, you would like to have a team have an immune system specialist also, meaning a rheumatoid arthritis specialist, a lupus doctor, etc., engaged in that, particularly when we know there's a lot of immune system disease and lung fibrosis. And so what we do is we do this exercise whereby we work together, and then what we do, as the title of this slide is meant to show, is we integrate the clinical with the radiologic with the pathologic, meaning the biopsy. So we want to integrate that grouping to reliably make a diagnosis. Now, how does this play out and what are the implications? Okay, so this is showing you three panels. Now, you're seeing the same picture in three places. This is a cut, and I just copied and pasted. This is a CAT scan of a patient that has the pattern of lung injury that we call usual interstitial pneumonia, or UIP, which is a honeycomb, scar, fibrotic pattern. And it's the pattern that we see with IPF. It's the only pattern we see with IPF. Now, what is this picture and what is this slide trying to tell you? This is trying to tell you the importance of that integration that I just talked about: clinical, radiologic, pathologic. So for this one, we're going to make it easy. The radiologic is the same. They all have the same picture, and it's the picture that looks like usual interstitial pneumonia, UIP. But now we're going to change the clinical and we're going to change the pathologic. And by doing so, we actually arrive at 3 different diseases. And this is confusing. It's confusing to lung docs, to rheumatologists. It's going to be confusing to patients. I'm trying to really explain how important that multidisciplinary interaction is and how important it is to integrate the story. The first panel is a man who has rheumatoid arthritis and has the autoantibodies, rheumatoid factor, RF, and CCP, the blood tests of rheumatoid, and has x-rays of rheumatoid and is on medications of rheumatoid. With that lung scan and the story of rheumatoid, this becomes rheumatoid lung fibrosis, and it's treated as such. We treat the rheumatoid. We use immunosuppression. Now maybe we're using antifibrotics. The middle category, what we call HP. Dr. Craig Glazer, UT Southwestern, he specializes in this, among other ILDs, but we certainly see a lot of environmental causes. So this patient has a different clinical story. He's had exposures as a construction worker. He has lots of pigeons at the construction site or at the house. And because of that, his doctor advised a lung biopsy. And that biopsy showed the findings of environmental injury. So we call that not rheumatoid lung and not IPF. We call that an environmental lung injury or environmental lung fibrosis, what we call hypersensitivity pneumonitis. And for that patient, we remove the exposure. We use immunosuppression. Maybe we use antifibrotics as well, but we do those other things as important aspects of the treatment. The third category has a different clinical story. This patient's clinical story is really not enlightening. The patient has high blood pressure and heartburn, like many of us, is a former smoker, but doesn't have suspicious exposures and goes to see perhaps a rheumatologist or gets blood work done, and there's nothing that looks autoimmune. This patient has no explanation and is called idiopathic. And because they have the UIP pattern, we can call that person idiopathic UIP, or more likely we call them idiopathic pulmonary fibrosis. So I'm highlighting the intersection that must go on to arrive at an accurate diagnosis, which then should impact treatment. What I wanted to do is give you now just a broad sort of strokes approach to some of the more common immune diseases that show up with lung fibrosis. We could do a webinar for each of these. We're not going to right now, but we're going to get you a high-level summary of some of the things that are important to keep in mind. So this is a CT scan of a patient that has an autoimmune disease that carries a few different names. We usually just call it scleroderma for thickened skin, but it's often called systemic sclerosis. This is a complex autoimmune disease. Many patients have skin thickening, not all, lots of other symptoms. But one of the things that we are aware of is that most of the patients with this autoimmune disease will have lung fibrosis. Seen in about 80 or 90% of the patients with this illness. Progressive in about a third. So it'll be there, not always progressive in nature, but it is the leading cause of death for patients with scleroderma, lung fibrosis. Now, I mentioned on the slide before that pattern called UIP, usual interstitial pneumonia. UIP, that pattern is rare in scleroderma. It's the second most common pattern, but it's rare to see it. About 10% of scleroderma patients, maybe 15%. So not all that rare, but it's not the most common pattern. The most common pattern is what we call NSIP, which is non-specific interstitial pneumonia. So this patient has a different lung injury pattern than IPF typically would. Now, what does a skin disease, scleroderma, thickened skin, have to do with the lungs? Well, I think it's a reminder that the immune system diseases are complex. We see lung fibrosis in most of our scleroderma patients. We see skin thickening in almost all of our scleroderma patients. But I would highlight that the title's misleading because the skin does not tend to inform much about the lungs. And that applies to most of the immune system diseases. So for example, there may be a lot of skin involvement in a scleroderma patient, but not much lung disease. There may be no skin involvement in a scleroderma patient and lots of lung disease. And so it's going to be important that we not hold fast to these rules. Well, if the skin is quiet, the lung has to be quiet. Or for rheumatoid, the joints are quiet, the lungs should be quiet. There's a lot of disconnect there. Importantly, a take-home message here is that this is an autoimmune disease that very commonly shows up with lung fibrosis. Now, the immune system is also complicated because we generate proteins in our blood that we call antibodies, autoantibodies. This is not a slide for memorization. It's just a slide to highlight that those proteins in the blood can often help the doctor understand more about what a patient may be experiencing or is likely to experience. Meaning if I saw a scleroderma patient and I knew that in their blood they had that gray box of a centromere protein in their blood, whatever the heck centromere is supposed to mean, right? But they have that protein in their blood, they are at highest risk for pulmonary hypertension, and they're at lower risk for progressive lung fibrosis. Or if they have that bottom antibody, that orange antibody, RNA polymerase 3, they're at highest risk for kidney involvement, but not much risk for the other complications. So those antibodies can be helpful, highlighting this intersection between the immune system and the lungs. I showed you CAT scans earlier because I wanted you all to appreciate how important they are in the evaluation. And for scleroderma patients, CAT scans are done routinely to look for lung fibrosis because we know 80 or 90% will have lung fibrosis. So a chest x-ray is not going to be adequate. You really need a dedicated high-resolution CT scan to know if a scleroderma patient has lung fibrosis. Another autoimmune disease that's mysterious and certainly confusing has a lot of different names as well. And that's called polymyositis or dermatomyositis. Now, myositis means muscle inflammation. Polymyositis means poly for many. There are many muscles that are inflamed. Dermatomyositis means there's a skin problem like rash as well as muscle inflammation. And the confusing part of this is that just like for scleroderma, which means thickened skin, I said that not everybody has thickened skin. Same with this. Not everybody with muscle inflammation as the name, myositis, actually has muscle inflammation because the immune system diseases don't always show up in uniform ways. Some of these individuals will just have lung fibrosis or a rash, and they won't have the muscle disease. Nonetheless, for reasons that are unclear to me, we still call them muscle inflammatory diseases. Now, why is interstitial lung disease important there? Well, most of the patients with these disorders will have interstitial lung disease. And lung fibrosis is the chief cause of death in these patients. Now, I showed you before a UIP that we see in IPF. I showed you NSIP that we see in scleroderma. For muscle inflammatory diseases, there's more heterogeneity in the lung injury. We see a lot of different patterns, and often the combination of patterns. And we talk about syndromes. This is a mysterious syndrome that I think anybody who takes care of lung fibrosis has become very familiar with. Patients usually haven't heard of this condition. Most of their doctors, before they get to a lung fibrosis specialist, haven't heard of these disorders. And they're unusual. They're unusual because A, they're rare, and B, you have to be a little bit of a detective to identify them. And for example, the key to this patient's story is looking at their hands. That's the hands on the bottom there that show coarseness, whereby we call it, it looks like the patient almost works as a mechanic and has kind of chewed up their fingers, and they're all almost eczematous in appearance. But that is the clue to the diagnosis, because we see this intersection between a skin problem and the lungs. Now, as all the audience here is looking at their hands right now, I want to be careful. That's not as simple as I'm saying it. It's just to highlight that that clinical piece has to be integrated. So if we see an individual who has hands that look like that, they describe the Raynaud's phenomenon of circulatory problems. We start thinking about these diseases, and we look at the imaging and try to determine, hey, does that imaging look like I might see in an autoimmune patient? Because this patient doesn't have an autoimmune disease as far as I know. They didn't show up with this diagnosis. They show up with shortness of breath and cough, and they have a CAT scan. But the astute physician, clinician, the doctor needs to look at more than just the lungs, ask about the immune system, and look for these clues. Here's another syndrome which we are becoming much more familiar with because we're seeing it worldwide now. This was initially only seen in Japan. And it's a very severe illness in most cases, but we're appreciating that it doesn't always have to be severe. The initial cases were all in the ICU and really uniformly fatal, but now we're seeing a wider spectrum. This is another autoimmune condition that has multiple facets. We call this a few different names. What it is it's that skin and lung intersection, really deep ulcerations in the skin, but they don't have muscle inflammation. So it falls into the family of muscle inflammation without muscle inflammation. Again, it doesn't make a lot of sense, but it's just sort of the conventional grouping. And what this is all about is deep skin ulcerations and rash with a very typically fulminant, very aggressive lung fibrosis, inflammatory disease. And the immune system is behind all of this, and there's an antibody that can be checked that's called MDA5. And so lung fibrosis doctors seeing patients with lung fibrosis, particularly when they have skin ulcerations, will assess for that protein to try to make the diagnosis. This slide is a reminder that the muscle inflammatory diseases are complicated. The box on the left, those patients will have associations with lung fibrosis. The box on the right don't have. I don't think we need to spend more time here, but it's really just to relay how complex this scenario is. And if you didn't believe me it was complex before, this one will get you dizzy. You might like this one. It might hang nicely over like the kitchen table, perhaps, if you removed all the letters. It's kind of artistically, I think, appealing to some extent. Either that, or I've spent too much time talking about autoantibodies, and I'm misguided in my art review. What this is trying to show you is that when we see the myositis patient, the muscle inflammatory patient, we can look at all of these antibodies, and all of these little circles here and bubbles are to reflect specific immune system proteins, what we call autoantibodies, that may give insight into whether or not a patient is at risk for lung fibrosis because of their muscle inflammation. And so you can see a ton of different antibodies, and each of them can tell us a little bit of a different story with regards to whether a patient is more or less likely to develop interstitial lung disease. And what's fascinating is the notion that there are theories out there and evidence to support that, for example, this disease, this anti-synthetase syndrome, may actually start in the lungs, meaning even though it's a muscle disease in many cases, even though it has a skin component in many cases, it's very possible that the initiating event that kicks off the entire immune system dysfunction starts in the lungs. So in this case, there's this release of an enzyme called JO1, named after the initials of the person in the lab that found it, JO. And what they identify is that with that release of that enzyme, it kicks off a complex immune system cascade that then leads ultimately to lung fibrosis, and it may lead to muscle inflammation, and it may lead to skin abnormalities. Rheumatoid arthritis, one of the most common autoimmune diseases that rheumatologists encounter. Rheumatoid affects about 1% of the population worldwide. And it's shocking to me about how well kept of a secret it has been that the lungs are a favorite target in rheumatoid. The joints are number one, right? The joints are definitely the most common organ involved in rheumatoid, but the lungs are number two. And people don't think about that. The eyes are a favorite target in rheumatoid. And it's important to keep in mind that this is not an arthritis. I mean, that's an insult to rheumatoid. It's not a joint problem, right? That's what football players and skiers get when they bust a hip or bust a knee. Where as we get older, we have that wear and tear. Those are arthritic conditions. Rheumatoid is an autoimmune disease. It's a systemic autoimmune disease. And by being systemic and being autoimmune, every organ's at risk, and rheumatoid loves the lungs. Now, it's important to know that there are not many rules with rheumatoid and the lungs, meaning sometimes it's very mild involvement and not even noticed. Sometimes it's very severe involvement and much more severe than any joint problem. Sometimes the lungs are involved and there isn't any joint component whatsoever. Heart disease is the number one killer in rheumatoid by a long shot, but lung-related deaths are number two. And so if a patient has rheumatoid and the doc isn't listening to their lungs, checking CAT scans or x-rays or doing lung function or giving some attention to the lungs, that's I think subpar. I think for a rheumatologist to take care of rheumatoid arthritis, the lungs are going to mandate some attention. And the other way is as follows. There are many patients that show up with lung fibrosis, and unbeknownst to the patient or the doc, sure enough, it's rheumatoid that's kind of the cause. I'm going to skip this slide here, and I don't like this slide either or that slide. I'm going to focus on this slide. What we know about rheumatoid arthritis and lung fibrosis is that it looks and behaves, perhaps more than any other autoimmune disease, it behaves and looks a lot like IPF, idiopathic pulmonary fibrosis, which is good and bad. I mean, it's good in the sense that there's a chance that the treatments for IPF can have a role in some of the treatments for rheumatoid lung fibrosis. And so the notion of using antifibrotics may make some sense in rheumatoid lung fibrosis in patients that have that. And it's bad in the sense that, IPF is one of our tougher lung fibrosis conditions. And it's possible that patients, because of the similarities, may have that same challenge that they have with IPF. And when you look at what the variables that are what we call poorly prognostic, meaning not good news, what we've learned about IPF is that older patients, male patients, lower socioeconomic status tend, as a group, those are bad predictors, so to speak. It never can work for a given patient, but as a group, we would say older men, lower socioeconomic status, those are poor prognostic features, and they're the same things we see in rheumatoid. Lung function is a prognostic variable. Really good lung function, good prognosis. Really bad lung function, not a good prognosis. Same with rheumatoid, same with IPF. More fibrosis, more of the UIP pattern, that usual interstitial pneumonia pattern of IPF. The more we see of that, the harder the scenario is. So those are some of the similarities between rheumatoid and lung fibrosis. This is a really complex slide, which I'm going to make pretty simple, I hope, in saying that sometimes in rheumatoid, the blood test for rheumatoid, so to speak, what we call anti-CCP, or you can also call it ACPA, these blood tests that we see in the blood of rheumatoid arthritis patients in many cases can also be associated with some information related to lung fibrosis. And what all this slide is telling us is that in a group of rheumatoid arthritis patients with lung fibrosis, higher levels of this antibody were associated with worsening of their lung fibrosis, more CAT scan evidence of lung fibrosis, more decline or lower lung function, more scarring, worse lung fibrosis in general, which then tells us that, again, the immune system and these antibodies can teach us about the lungs. And what we know now about rheumatoid is that if you think back now about a slide about 40 slides ago where I asked, why do some of these autoimmune diseases have lung fibrosis and why don't others? We don't really know, but we are learning more. And if we were to say, tell us about this rheumatoid lung connection, what do we know who's at risk? Well, in general, men more than women. There's more lung fibrosis in men with rheumatoid than women. Older, prior smoking, a certain genetic background, which we call the shared epitope, or HLA-DR, that's a gene. A blood test for rheumatoid, these CCP are rheumatoid factors. A different blood test that was shown at least in one center. Worsening arthritis, although I'll tell you there are lots of joint and lung disconnects, meaning many patients have really bad joint disease, not much lung involvement, really bad lung involvement, no joint involvement. A lot of disconnects. And then there's a gene called MUC5B. Now, I show this slide, but I would say this is not a perfect story by any stretch. Many men, many older smokers with these antibodies don't get bad lung fibrosis. Okay, and then on the other side, there are many women who haven't smoked, who don't have these genes, who don't have much in the way of joint involvement, can also get lung fibrosis. So this is not a hard and fast rule. There's a lot of gray here, but we are trying our best to understand more and more about who with rheumatoid gets lung fibrosis. I'm going to show you a couple of cool slides right here. This is a question that we're learning more and more about, and a scenario I think that's playing out. This is out of work at the University of Colorado that Shelley mentioned when they first began interacting with me and heard about some of the research we were doing. This is from more on my colleague's side than myself. Kristen Demerel is a doctor at the University of Colorado, and she works with a team there that is investigating this scenario. That basic premise is that there's a phased approach to how a patient develops rheumatoid arthritis. So phase 3 is that they have rheumatoid arthritis. But if you go back in time, there's a genetic component. A patient may have a genetic risk. And within that context, then there's some environmental exposure. Let's say it's smoking. So we have a genetic risk. We have a smoking-related injury in the lungs that kicks off this immune cascade. I'll show it even better on this next picture. There's a smoking-related injury in the environment, and somehow the individual is at risk, and it affects the lining of the lungs. And so now there's lung inflammation that's been generated. That lung inflammation kicks off the immune system to get dysregulated, to become dysfunctional. And then that immune system dysfunction, because it's blood-based, will then spread through the body. And in the case of rheumatoid, it may show up as joint-based inflammation. But the message here is that it's possible that the initial injury was in the lungs, where there was an environmental injury that caused immune system dysregulation. I'm going to move ahead just to this concept that there are, well, let me show that slide, that there are patients that really confound us and push us to acknowledge that there's a lot of gray in medicine. This is a former patient of mine who I saw that we initially thought may have IPF. The CAT scan there looks like a scan that we would see in IPF. It looks like it would be that pattern of UIP. But when I talked to her and saw her, there were a couple of things that, as a rheumatologist, got my attention. She had some circulation problems called Raynaud's phenomenon, which many people have, but it is one of the markers that we can see in autoimmune disease. She had an antibody, an immune marker. And we actually did a lung biopsy, and the lung biopsy showed that there was a lot of inflammation. And the pathologist said, boy, that's a lot of inflammation. Does this patient have an autoimmune disease? And the answer was probably yes. But we didn't have enough to say this is rheumatoid or this is lupus or scleroderma. And so the message here is that there are many patients that sit in an area of gray, whereby we see a scan, we hear a story, they look autoimmune, they might smell autoimmune, so to speak, in a colloquial sense, but we can't really label it as rheumatoid arthritis. We can't really label it as lupus. And there's some areas of uncertainty there. And these patients are now being called really in a one term, IPAF, or an IPAF means they have interstitial pneumonia, that's the IP, and they have autoimmune features or an autoimmune flavor. So they look to be autoimmune by some sense, but they may not have that full-blown autoimmune disease. And this is a term that has helped, I think, lung doctors and rheumatologists talk in the same language, meaning this is not rheumatoid arthritis or this is not lupus, but we acknowledge that it's autoimmune in nature. This is an area of research investigation, which I think does have clinical implications, because people can now begin to think about IPAF as a clinical scenario. This is really an autoimmune condition in evolution. But I would highlight that this remains in large measure a research concept that needs more evidence. But I think it has given patients and doctors an opportunity to appreciate the complexity between the immune system and the lungs. And what this slide is trying to show is that there are folks that literally fall between these spectrums. On the right, you have a very classic autoimmune disease, let's say lupus, let's say rheumatoid. And on the far left, you have patients that don't have features of an immune system problem. But in the middle, you may have patients that have something about them that looks autoimmune in nature. Now, over the next 5 to 6 or so minutes before I close, I just wanted to walk through some basic concepts that apply to the immune system and lung fibrosis scenarios, and really apply to interstitial lung disease in general. And the key here is that it takes a lot for us to be able to evaluate patients. We need to look at a lot of variables. We need to look at and understand patients and how they're feeling. And we need to also look at test results to help us understand how patients are doing. And a very central point is that when you talk about the treatment, you know, there are some patients with lung fibrosis that have stable, maybe relatively mild, untreated. And if they're stable and they remain relatively mild, it's not clear that they need treatment. And so we want to reserve treatment for those patients that have more significant disease, and certainly those that are getting worse. This picture just highlights the complexity. Here's the patient in the middle. They have an autoimmune lung disease. They have lung fibrosis related to scleroderma. Change that up if you'd like. Make it IPF or make it rheumatoid lung fibrosis. What we need to do and what patients need to keep, I think us on task about is ensuring that we're addressing all of these issues, the symptoms, whether or not there are other factors impacting our patients, looking for other causes of lung problems or heart disease that may be impacting symptoms, what the CAT scan showing, what the lung function's doing. And if we're not integrating all of that, we're really not providing the comprehensive care that patients need. And we follow lung function over time. Look at bullet 4. We trend the forced vital capacity, the DLCO, over time. How is my FVC now? How was it 6 months ago? How was it 2 years ago? And we should be able to map that out to tell our patients how they're doing. So we'll put a chart put a graph in a patient chart like these pictures on the right. Over the time course of months, how is a patient's forced vital capacity? How is a patient's diffusing capacity? We care about their symptoms. We want to know how they're feeling. We also want to know how their lung function is doing. We want to know how their walk test is doing. And we want to see what their imaging looks like. And all of those pieces need to be integrated as we manage patients. I don't love that bumper sticker, stability equals success. I would say we have a long way to go in lung fibrosis care. We should have success being, reversal. Success is eradication. Success is curing the lung fibrosis. It's not where we are right now. Where we are right now is there are some lung fibrosis conditions that are mostly inflammatory. And oftentimes those are some of the immune system ones. And when there's a lot of inflammation and they're very inflammatory, we often can say we can reverse. Not cure, but we can reverse. We can resolve. But once there's scarring, once there's true fibrosis, then we're really looking at, in the current era, how do we keep our patients stable? How do we ensure they're not getting worse? I look forward to the day where we have anti-fibrotic medications that truly reverse. Pirfenidone and nintedanib have been game changers in helping so many patients, but they're not reversing disease. They're slowing the decline. They're helping stabilize. Now, I mentioned before we have to be comprehensive, and that's really going to be important. And that's where we talk about not just antifibrotics, but we want to break these cycles of being sedentary. We want our patients to exercise. We want them in pulmonary rehab. We want to make sure we're using supplemental oxygen. We're treating other conditions. We're doing the immunizations. We're taking care of the whole patient. And it's not just about antifibrotic therapy. And my last slide or two here is just to where we may be heading, which is going back in time, thinking about those slides I showed you about what the treatment paradigm looked like, where basically everybody on the left, IPF, post-October of 2014, now has access to pirfenidone and nintedanib. Well, things are changing with the spectrum on the right. And that's an appreciation that there are a lot of patients that have lung fibrosis, even though it's not IPF, but they have lung fibrosis and they have progression. And there's a lot of scarring there. There's a lot of that fibrosis there. Why can't we take those anti-fibrotic drugs and try them there too? And that's what's happening. And if you look at that right side of the screen, we're looking at patients and saying, do they have fibrosis? Is it getting worse? Can't I use an antifibrotic just like I use them in IPF? I think we're learning you probably can in certain circumstances. And you may also want to combine them with immunosuppression. And so the field is evolving whereby future patients may be getting these antifibrotics or already are getting them because they have lung fibrosis. It's not IPF, but they have lung fibrosis and it's getting worse. And so if you think back now to those scenarios that I painted a while ago about these different patients may be treated differently, well, in a lot of cases, these patients now are getting treated similarly. Yes, rheumatoid, they need immunosuppression for their arthritis and for the immune components, but maybe an antifibrotic makes sense there too. That middle category, environment, clean up the environment, remove the offending agent, but maybe they also benefit from an antifibrotic. And we know that IPF patients are benefiting from pirfenidone or nintedanib. So my summary of this, I think, complex arena is really point number one. This is an area that we need to be working together. And so having multiple specialists interacting is really critical. I've highlighted that there are lots of implications between the immune system and the lungs, lots of connections, but also disconnections, meaning the joints are quiet, the lungs are active. The skin is absent or the skin is present, doesn't always tell us what's going on with the lungs. And these muscle inflammatory diseases where you don't even have to have muscle inflammation. And yet we see all these antibodies, proteins that point to the immune system. I told you that there are theories about rheumatoid starting in the lungs, the muscle inflammatory diseases perhaps starting in the lungs. That's important to keep in mind as we see lung fibrosis patients. I shared with you that sometimes the scenario is gray. Bullet 4. When we define autoimmunity, not always clear. That doesn't look autoimmune to me, but it looks autoimmune to the pathologist. And so we can find scenarios, that IPATH story, where we think it looks autoimmune, we're not sure. Point 5 is that we talk about antifibrotics, but it's important to remember the other things. Oxygen, pulmonary rehab, taking care of the whole patient. I wanted to highlight that point 6, for autoimmune patients, we use immunosuppression still. For IPF, we tend not to. But immunosuppression can still be helpful, and it may be combined with antifibrotics, and I think that those antifibrotics give us reason for hope. And my last point is that we are in a period of time where the treatment landscape continues to evolve. clinical trials in lung fibrosis, extending beyond IPF, all options, and all, I think, offering hope for the future. And then again, I just wanted to thank you all for taking time out of your day to listen and participate in this presentation. And wanted to give a major shout out to PF Warriors and all that you're doing to change lives and help advance what we learn and understand about lung fibrosis, and giving a lot of support and hope to many, many thousands of patients around the world. Thank you very, very much for this opportunity.
Well, Dr. Fischer, before we start, I know you want to, you've generously offered to help us get a better view and understanding of a very complex issue, but I am personally awed by the complexity and the importance of a good, solid diagnosis, which I think only comes from an ILD center. And those listening here and listening elsewhere, I would encourage you to pursue a diagnosis, because it sounds to me like that's the stepping stone to some success for us patients. We're going to open up the floor for discussion and questions and answers. Keep in mind that Dr. Fischer has limitations on what he can talk about relative to Bristol Myers. I'd appreciate you not treating him as a doctor asking questions for your own diagnosis, but from his perspective of what he's bringing to us as a generous offer of time and energy. And I think many of us have questions. I've already received a handful from people asking questions of me, which I'm not the guy, I'm just the conduit to the guy, and the guy is right there. So I'd say please unmute your mic when you ask your questions, and then mute your mic, please, when you're done, so we don't kind of trample over each other. So with that, I know a number of you has good questions. One that comes to mind is Cyril Patrick Fernandez. Patrick, if you'll unmute yourself and ask your question, because I know Dr. Fischer will be interested in hearing it.
Hi, Dr. Fischer. That was an excellent presentation and very illuminating. A comment and then a question. I'm a lung transplant patient for 1 year, and I'm back to full health, live an active life. But one of the things for longevity is autoimmune suppressant. We will live for a median of 7 years, where 50% of people live and 50% don't live. And the trigger for this is autoimmune. In other words, rejection of the new lung. And in the future, there's got to be more and more studies why some people die less than 7 years and other people live on to 20 years. So it can go as long as 20 years right now. Now my question. Why you had mentioned earlier in your presentation that the immunosuppressant treatment for IPF can be harmful. And I wondered at the molecular level or physiological level, how is it harmful? And the second part of that question is when I was diagnosed with IPF and it looked as bad as the lungs you showed, they gave me immunosuppressant because of a very high rheumatoid factor. It was 82. And they checked me for rheumatoid arthritis and rheumatoid, and I was shown not to have rheumatoid at all. So I wondered the connection between high RF factor, no rheumatoid, and the harmfulness of immunosuppressant.
Sure. First of all, nice to meet you. Congrats, and amazing. It sounds like you've had quite a story and surviving IPF and getting a lung transplant. Stay well, and don't get too bogged down on those statistics. Remember, they don't really help the given individual patient. So keep beating whatever odds your doctor's telling you about. Just keep staying well. Couple things. Blood tests can be confusing. Rheumatoid factor, which you heard a little bit about from me, but not a lot. I didn't focus much on it because it's not a great blood test. There are a lot of people who have a positive rheumatoid factor, and they have it because they may have a hepatitis infection, or they may have tuberculosis, or they may have rheumatoid arthritis or lupus, or they may have none of those problems. A positive rheumatoid factor, not very helpful. Now, I don't know why you were given immunosuppression, but sometimes when there's a hint that the immune system is involved, sure, a short-term course to see if a patient responds makes some sense. But I would just be careful that we don't sometimes over-rely on blood tests, particularly some of the blood tests that are not as helpful. Immunosuppression in IPF has been studied. Not a short-term course of high-dose steroids, but I'm talking about sustained, 10 to 20 milligrams over a course of a number of months or a year using azathioprine. And for reasons that we don't understand well, patients who have been treated with that regimen, at least in one clinical trial, they did worse. They had more hospitalizations, higher mortality. And so it just raises the spectrum of caution that for IPF, not for every patient, but as a general rule for IPF, people tend to avoid chronic medications like azathioprine, Imuran. Doesn't mean that you can't be on it. It just means that some of the studies have given us a sense of we should proceed with caution. I don't know why molecularly that happens, but I do know that practically patients with lung fibrosis are at risk for infection, and it's possible that when you suppress immunosuppress patients, that they have more infectious problems. That's a theory. What's interesting now about your story, and I think applies many to other patients, right now your immune system needs to be suppressed because you've had a transplant. And it's not the autoimmune system that needs to be suppressed, it's the immune system, meaning your body is not attacking itself. Your body wants to, in general, identify this foreign organ and make trouble. And so the doctors now need to suppress the immune system so that foreign rejection doesn't occur. So there is always going to be roles for immunosuppression in lung fibrosis as something to consider, and every case has to be taken care of individually. I think your story highlights some of the challenges. A blood test that maybe led to some confusion about a diagnosis, and now being suppressed because you're at risk for rejection, and the important point now is to suppress your immune system. Stay well.
If you have a question, please turn off your mic and ask Dr. Fischer.
I have a question. Thank you, Dr. Fischer. I'm curious, I just recently had a triple wedge resection and biopsy. All my serology was negative, all the pathology was negative for anything besides IPF. I mean, that was the conclusion for the multidisciplinary team, which did not include a rheumatologist, I'm sorry to say. But how often do you see a patient with an IPF diagnosis later start to manifest evidence of autoimmune disease?
It's a great question, and it happens. And it, I don't have a number, but I would say a couple things. The fact that you're a woman with IPF should raise people's radar that this is a little bit unusual, okay? One of my mentors, a senior lung fibrosis specialist, would say, they always felt a little bit uncertain about that IPF diagnosis in a woman because the autoimmune diseases seem to be so much more common in women, and IPF is such a male-dominated disease. I'm not saying you don't have IPF. I would just say people need to keep in mind, I think it's important for you, your question's spot on. It's possible, right? That the lung fibrosis was the first, and the potential that your story evolves is there. And so I think it would be important for you and your docs to keep that in mind, right? So here's your diagnosis, IPF, get treated accordingly, get assessed accordingly, but periodically, and particularly if new things are occurring and new symptoms are developing, new problems are showing up, I don't wish that on you, but it's important that that be kept in mind because it's possible that the story evolves. We see that. The patient was called IPF. 6 years later, 10 years later, they developed the inflammation in the joints of rheumatoid. And then you put the story together. And it can take that long.
Dr. Fischer, I have one other question about the study the SARA study that my husband was in Colorado. One of the things that within that study, they had another study about mouth bacteria, like a rogue bacteria or protein gets into the lungs and kicks off the inflammation.
That's right.
Did anything go with that study?
Yeah, so there are a number of theories out there. So I mentioned for rheumatoid the theory that the environmental injury is in the lungs, but the lungs are one portal of entry, okay? One portal of entry. Where else are there portal of entry? So we're all going to go back to anatomy class here, our mouths, okay? Where else? The gastrointestinal tract. Where else? The genitourinary tract. People are looking, and that same group is looking at periodontal gum disease. In women, gynecologic related inflammation, gastrointestinal disease. And so the notion that the immune system disruption can occur at any of these areas where we have environmental to internal organ engagement. And that's still a story playing out.
Okay, I have just a couple of quick questions. Number one, what's the impact percentage-wise of 3,000 milligrams of mycophenolate that I'm on for ILD and systemic sclerosis? What's the impact to the immune system percentage-wise? I'm just curious. Is it reduced? Does it suppress at 25, 50?
Yeah, it's a question that your question is going to be better than my answer. The reality is that mycophenolate is a drug that's used for transplants, right? Kidney transplant, lung transplant. It's used in lupus patients. It's used in lung fibrosis patients. We know that it suppresses the immune system by its mechanism of action. It targets T cells, a component of the white blood cell. It targets B cells, another component of the white blood cell population. And that's sort of how it works. It modulates the immune system. Now, that being said, I would take care of patients with mycophenolate. They're on 3,000. They don't even get a common cold. They walk through as if they're not even on anything for their immune system. And so for some people, it doesn't do anything in practicality to their host defense. It does enough to suppress the immune system and the disease, but it doesn't manifest with a common cold at 3,000 or 4,000 milligrams. And yet I give a patient 500 milligrams, a small dose, and they would be in the hospital with pneumonia. Some people, for reasons that we don't understand, are much more sensitive to some of these immunosuppressive agents, and they suppress their immune system to the point that they can't stay on them because of recurrent infection. I didn't see much of that with mycophenolate. I'll tell you, I was really impressed with how little in the way of infections I saw with mycophenolate. And so even though it theoretically suppresses the immune system and modulates it, we didn't see a ton of infections. Would I tell my patients who are on mycophenolate to be wary of infection, to be on the guard, get your immunizations? Absolutely. But like I said, I think your question is better than my answer. There are a lot of people who are on that drug. It's working for their disease, and we see no practical immune system side effects.
Great. Thank you so much. One other part that I think everybody would be interested in, with all the talk about COVID and what the vaccines are that they're coming up with, everything I read says these vaccines are immune boosters, and especially for older people that are at risk like us. And so I'm again on mycophenolate. And I mean, is this something I really want to do, is boost my immune system? Or is this selective where it just will boost the immune system against the virus?
You know, first of all, boy, I can't wait till we have a vaccine for COVID. I don't know about you guys, right? So I look forward to having a successful vaccine to be able to make some tough choices about. But right now we don't have a vaccine. So again, I'm like you all, enthusiastic about that day when we have that option. I'll say the following. We have lots of immunizations that we've learned about, influenza, pneumonia, measles, shingles. And for immunosuppressed patients, the biggest issue is we got to worry about those live vaccines. Vaccines that are live pose a risk to immunocompromised patients because they could actually get the infection that we're trying to prevent from the vaccine. So if we get a COVID vaccine, and hopefully we do in the near future, if it's a dead vaccine like a flu shot or the pneumonia vaccine, we're not going to see any trouble in our immunocompromised patients. If we have a live vaccine, we're going to have the issue of, well, we got the balance between how bad COVID is, and now we got a live vaccine. So that might be more tricky. But I look forward to that conversation, sir.
I have a question.
I have a question about.
Go ahead.
Sorry, I had a
my
question
dad
about A and A.
yeah.
If you could.
Oh, no, that's right. I'll wait.
Go ahead, Kill. Kill, you're trying to get in there, so please go ahead, Kill.
Okay. I was just wondering. So I fall in the IPATH category, and the marker that put me there was having a very high ANA, but no other clinological or other factors. And I was wondering if you could help explain, what does that really mean, or what is that telling me? I've had this for 11 years now, and for the first 5 or 6 years, I was not very affected at all, and my disease was fairly stable. And then in the last 5 years, my ANA grew from 320 to 640 to 1280. It eventually maxed out. And as my ANA rose, I started going on oxygen for exertion, and my fibrosis got worse. Started progressing pretty rapidly. So I was wondering if there's any tie in there or connection.
Yeah. So not being, on site, seeing all the specifics, I'll just speak broadly. ANAs are another blood test that can lead to confusion, but they do often raise people's attention. And if you're, what appears to be, a younger man with a high titer ANA, that should get everyone's attention, and that should alert that the immune system is probably at play. The fact that you're looking at a prolonged course, I mentioned earlier that the autoimmune patient tends to do better and sort of live longer and have a slower trajectory. That too should raise the spectrum if that's what's happening perhaps in your case. The blood test itself doesn't make a diagnosis. It's just an immune surveillance marker. My summary would be, boy, you've had lung fibrosis for a long time. You have this circulating autoimmune marker. I think you look like somebody that has this autoimmune flavor, even if it's not a clear-cut diagnosis. And I think your doctors are probably onto something with regards to how they're approaching you by calling this IPATH and perhaps treating you in the immune spectrum, not just as an IPF type scenario.
Yeah, we have time for one more question, because Dr. Fischer has been so generous with his time, but his time is precious and limited. So one more question, please.
I have a clinical trial question. When, due to the current problem with the virus, screening for clinical trials has been postponed until further notice.
Yeah.
When clinical trials reopen for new subjects, say at Duke University?
You raise a good point about the challenges that the pandemic has thrust upon us, which is that we have a desperate need for clinical trials, and we're put on hold because of the current, arrangement. I'll tell you, from the standpoint of our company, we are looking to launch clinical trials in places that we're able to. And so I can't speak for Duke University other than I can comment that there is now an effort, certainly at BMS, to begin opening clinical trials at sites as the pandemic will allow. My hope is that, as we as a country and certainly globally get the pandemic under better control, that we can begin to resume clinical trials. But certain mandates need to be put in place and safety parameters to ensure that. So I don't have a concrete answer other than to tell you, I could promise you that BMS and other companies like us are very invested in trying to relaunch trials because they're the foundation of finding future therapies.
Dr. Fischer, I have to tell you that this has been just an exceptional meeting. I have been galvanized to recognize the complexity of diagnosis. I had forgotten that for a while, and it's going to kind of re-challenge me to carry that message forward to our membership and our network of supporters. It's so critically important, and you did a smashing job, and thank you. We all thank you. You can't hear the applause, but it's deafening, but thank you so much.
Thank you all.
And all of you that are here, if you're not a member of PF Warriors, please join us, pfwarriors.com. Love to see you sign up, become part of our growing family. We're now 2,000 people globally. I'd like to see that to be 5,000 by the end of the year. So we can do it, but it's going to take all of us pulling in the same direction to do it. So one more time, Dr. Fischer, thank you.
Thank you all. Bye-bye.
Bye-bye.